Okay, we'll get started. So thank you to everyone joining online and in person for the first session of this year's WHRI Summer Scholar Series event. My name is Paul Young, the WHRI Assistant Director. We begin by acknowledging that the WHRI operates on the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations. Further, this acknowledgement, gratitude, and respect extends to all the First Nations communities on whose traditional territories the WHRI builds relationships. 2026 marks the fourth annual Summer Scholar Series event, with this year's theme being Building Bridges in Research, Embracing Interdisciplinary Collaboration and Expanding Your Network. We are pleased to welcome Dr. Gillian Hanley, our newly appointed Executive Director of the WHRI. Dr. Hanley is also an Associate Professor in the Department of OBGYN at UBC. She's a Canada Research Chair in Population-Based Gynecologic and Perinatal Outcomes and an international leader in ovarian cancer prevention. She has interdisciplinary training in economics, health services research, and epidemiology, and frequently works with clinical and basic science colleagues. Today, Dr. Hanley will share her journey in becoming an interdisciplinary researcher, along with tips and strategies for making the most of interdisciplinary research and collaboration. Before we begin, for in-person attendees, please press the button on your microphone to activate it during Q&A. For online participants, you may submit your questions via the chat, and the communications team will ensure they are relayed to Dr. Hanley. We also invite you to come to the two next sessions, July 8th with Dr. Bingham and July 29th with Dr. Clausen. Registration for these events are available through Eventbrite, accessible via WHRI's website and by social media. Finally, concluding this event series, we'll be circulating an evaluation form in August and would greatly appreciate your feedback. Please join me in welcoming Dr. Gillian Hanley.
Thank you. So the part that Paul didn't warn you about is that I'm going to force you all to participate because I can't spend an hour talking about this without hearing from all of you. So yes, I'm going to talk about building bridges in research. So fostering interdisciplinary collaboration and expanding your workshop. And you will note that expanding your network, and you'll note that I called this an interactive workshop. So that means you have to participate. Okay, so why are we here? Ultimately, we want to leave with new connections, although you all might already know each other. It's a chance for me to get to know some of you who I might not already know. Practical collaboration strategies, and then maybe think about one action that you'll take this month in terms of building interdisciplinary collaboration or increasing your network. So I think maybe, Olivia, do you have a sense of how easy it would be to include people online in the discussion and all of that? Okay. It would be great if we could do some quick introductions to see who's in the room. Then we'll have a discussion about some of your research challenges. Then I'll talk a little bit about my research experiences, and we'll do some back and forth around some specific discussion questions, and then also some activities. So I think Paul gave me a really nice introduction, so maybe we'll start with you, Catherine.
Hi, everybody. I'm Catherine Brewer. I'm the Senior Research Manager here at the WHRI. Sorry, I'll do it again. Hi, everybody. I'm Catherine Dewar. I'm the Senior Research Manager at the WHRI.
Emma.
Hi, everybody. I'm Emma. I'm Research Coordinator for the Endometriosis and Pelvic Pain Lab, working with Paul.
I can go because I'm also Emma. I'm a research manager with the Reproductive Infectious Diseases Program, working with Dr. Money.
I'm Maddie. I'm a summer student working with the Reproductive Infectious Disease team.
Hi, I'm Jenna. I'm a research coordinator with the RID team.
Hi, I'm Sophia. I'm a research assistant with the RID team.
I'm Henry. I'm a research assistant with the RID team as well.
Whoa, lots of RID team members.
Sabrina, I'm also a research assistant with the RID team.
Behind Sabrina.
Hi, my name is Ethan. I'm postdoctoral researcher at the Institute of Global Health.
Julia.
Sorry. Hello, my name is Julia. I am the qualitative research analyst at the WHRI.
Soraya.
Hi, I'm Soraya. I'm not in research right now, but I am the finance admin for WHRI.
Hi, I'm Rebecca. I'm executive assistant to Dr. Gillian Hanley in the WHRI.
Sure. Hi, everyone. I'm Olivia. I'm the communications assistant at the WHRI.
And are we able to hear from some of the people online?
Yes, yeah, folks can unmute themselves to introduce themselves or raise their hand online to participate. Yeah. Unmute Claire. Lena?
Hi, guys. My name is Lena Likai. I'm the Research Operations Manager at the new Clinical Trials Unit at Mount St. Joseph Hospital.
Rachel has her hand up.
Hi, folks. Thanks so much. And apologies, I'm not able to be there in person today. I'm just on my way off site, so hopefully I'll catch the next one. But I'm Rachel. I'm a nurse practitioner at BC Women's in 3 different clinics and also do some research activities as part of my role.
Jennifer, are you there?
I am, yes. Hi. My name is Jennifer Roy, and I'm a nurse educator on the sexually transmitted and bloodborne infections team at the CDC. And I will be starting a PhD in the fall at UBC in the School of Nursing.
Thank you.
Naomi, I saw you there as well.
Claire, would you like to go?
Yeah. Hi, Naomi. You can introduce yourself.
I'm the research assistant with TMIST and also the maternal newborn program.
Thank you. Okay, does anybody else online want to introduce themselves? Oh, Melina?
Hi, everyone. My name's Melina. I'm a postdoctoral research fellow at UBC, and Dr. Hanley is one of my supervisors. Thank you.
Anyone else?
Hi, my name is
Haley.
Afifa.
Sorry, go ahead, Alfifa.
My name is Afifa, and I recently finished my PhD from SFU. My work area is women's health, and I also do some research work at SFU.
Thank you. I think I saw Alice and Haley.
I can jump in. Hi, everyone. My name's Haley. I am the Digital Health Research Manager for WHRI.
Thank you. Alice, did you want to say hello?
Hi, sorry, just jumping in a little bit late. My name is Alice. I'm an undergraduate research assistant with Dr. Gillian Hanley.
Okay, thank you. I know there's more people on. Oh, there's Nicole.
Sorry. Hi, Nicole Presley, Knowledge Translation Manager at the WHRI.
Thank you. Okay, so just the first question to kind of start to think about, ways that interdisciplinary research can actually help us. What is the biggest challenge in your research right now? RID team. What is the biggest challenge in the RID team right now?
I think one challenge we have, we're writing a grant that actually is pulling together interdisciplinary work. It's about the vaginal microbiome in menopause, and we're having a hard time like really selling the story of this grant. So it's been on top of mind for a lot of us recently.
Yeah. And what, like, you understand the importance of the work, but you're having a hard time knowing how to tell that story to a different audience, or?
Yeah, and I think like we've applied a few times to CIHR, and it's just not like landed why this is really important and why it matters. And I think there's some biases there, but also it's on us to really explain why this is so important. And so, yeah, it's been a challenge, and we keep changing things to try and respond to reviewers' feedback, and then things get muddled, and yeah, we're sort of,
you get a totally new set of reviewers that have totally different.
And they're like, why didn't you say this? And we said it before, we said it last time.
Yes. Yes. Okay. Anybody else want to mention a challenge that they're facing? Yeah, so I mean, not always, obviously, but I think many times challenges, sometimes unexpected answers to research challenges can come from people in different disciplines. And, even like a slightly different spin on a grant, or adding one sort of component to a grant that wasn't previously there before, that just coalesces everything, brings it all together. So I'm going to provide an example of that with one of our projects later. But I think, there are many challenges where some form of interdisciplinary collaboration, or even just a fresh set of eyes in terms of a different disciplinary take on the research question at hand, can be incredibly valuable. And of course, research is a team sport. So my experience has been that the most impactful research that I've been able to do throughout my career really has required diverse expertise, because generally speaking, we can get so far with our own skills and our own experience, but you will get to a point where if you want to take the next step to truly make clinical impact, or change outcomes for a population, you're going to need to answer a question that you may not have the specific skills to answer yourself. So, for example, we've been working in the area of endometriosis-associated ovarian cancers, obviously with Paul and other collaborators. And one of the really important questions there is to endometriosis is a very common benign gynecologic disease. Endometriosis-associated ovarian cancers are very rare, but they do occur at a much higher rate in people with endometriosis. So really what we need to be able to do is to distinguish between endometriosis that is unlikely to undergo malignant transformation and endometriosis that is likely to undergo malignant transformation. And so I don't personally have the skills to do that kind of lab-based work, but collaborating with folks like Paul and other laboratory-based researchers to try to answer those kinds of questions. And I would say there are very few truly groundbreaking discoveries in science that have not been made with the collaboration of many. So I was actually at a lecture last week, and it was for Nellie Ausberg, who was a really heavy hitter in ovarian cancer research. at UBC for many, many years. And somebody put up a slide that showed 3 single authored publications in Nature that Nellie had done in 1 year. I mean, that just does not happen anymore, right? Like, first of all, nobody gets 3 Nature publications in a year, but you absolutely cannot publish in Nature as a single author anymore. Most Nature publications have authorship lists this long because the amount of data, the amount of analytic support that you need to get a Nature publication is so considerable that you're going to have a team of 100 people for most of those publications, because that is how the truly groundbreaking, hard-hitting science is done now. So I have a very interdisciplinary background. I actually have a master's degree in economics, which I don't use very often anymore. But I was doing an undergraduate degree in biology and economics, and I went to hear a talk from Bob Evans, who's a really famous health economist, but he ended up becoming more of a health services researcher and had, I think, a really big impact on healthcare and health services research in Canada. And he was giving this impassioned speech about how, many people in the room probably wanted to go to medical school. And I thought that was the route that I would likely go down. But actually, you can have a real effect on health and healthcare by doing research. And so he convinced me that I should get a master's degree in economics, which maybe wasn't quite the right path, but, got me close to the right path. And then after that, I did a degree at the School of Population and Public Health back when it was called Healthcare and Epidemiology. And then I ended up connecting with the folks at OVCare to do work in gynecologic oncology. And now I work much more broadly in women's health across many different areas, because for me, one of the things that I really love is data. So I really like to identify existing sources of data, determine how we can make use of those to answer research questions that we couldn't otherwise answer, and then consider, ways to link data to biospecimens, to researcher collected data, and all of these different uses that we can put to data in order to open up research avenues that maybe previously weren't obvious or available to us. And largely, I like to work in areas where randomized control trials are not really possible. And so those are the cases where, turning to unique observational data sources are really fruitful, because we're not going to be able to run randomized controlled trials. So one of the areas we were just chatting about before we started is prescription medication use during pregnancy, for example. So, it's never going to be ethical to randomize pregnant people to take a medication or not to take a medication. But pregnant people often have conditions in which they need to continue using their medication. So we can use observational research to shed light on that. But one of the other things that, taking a very circuitous route to where I ultimately ended up, is that you learn that different disciplines have very different ways of thinking about problems, and there are often strengths and weaknesses to, the way many different disciplines traditionally approach problems in health and healthcare. And so being able to learn from all of those and to take the parts that were meaningful and to leave behind the parts that were less so was a useful exercise for me. Okay, so an example of some interdisciplinary collaboration work that I've done over my career would be in the area of opportunistic salpingectomy. Has everybody heard about opportunistic salpingectomy in the room? No, there's a few people shaking their head no. Okay, you haven't been hanging around long enough in these circles. So opportunistic self-injectomy is what this picture is showing, which is the removal of the fallopian tubes during another surgery. So it's called opportunistic because it has absolutely nothing to do with a person's risk for ovarian cancer, but is entirely based on the fact that they're having another surgery in which you can take advantage of the opportunity to reduce their risk for high-grade serous ovarian cancer. High-grade serous ovarian cancer is the most common and the most lethal form of ovarian cancer. We cannot screen for it, and 5-year survival rates are about 30%. So we don't do a very good job of keeping people alive once they are diagnosed with it. It is largely asymptomatic until it's already an advanced disease. So for a long time, people thought that educating people about symptoms or trying to do ultrasound-based screening might work. None of those things work because by the time you can find it on ultrasound, it's already advanced stage. By the time anyone has a symptom, it's already advanced stage. So the best thing we can do for this cancer is to try to prevent it. And in September of 2010, the ovarian cancer research team, led by Dr. Diane Miller, who you can see on the screen there, had an idea that maybe we could prevent it by removing fallopian tubes. And that sounds very odd, to prevent ovarian cancer by removing a different part of the anatomy, but it turns out that these cancers actually originate in the fimbriated end of the fallopian tube and not on the ovarian surface. And of course, we don't want to remove ovaries in people who are at general population level risk for ovarian cancer, because we know that putting somebody into premature surgical menopause comes with a whole host of downstream consequences, and we would end up doing more harm than good for many people because ovarian cancer is quite rare. So the idea was, if we don't actually need to remove the ovaries to prevent these, but can remove fallopian tubes instead, maybe we should start doing that at the time of hysterectomy, or for people who are seeking permanent contraception in the form of tubal ligation or tubal occlusion. And Diane started calling this opportunistic self-injectomy to really highlight the fact that it doesn't have anything to do with somebody's risk for ovarian cancer. It's just about a surgical opportunity. And so we've done a lot of work here around this to show that this is safe. So, you know, lots and lots of papers looking at safety evidence, and not just us, many people around the world have been doing this kind of work as well. And, you know, recently there was a randomized controlled trial that was done in Sweden that reported out on their safety data. And they found exactly the same thing that all the observational data had been showing for many, many years, which is that this is very, very safe. And then we've also shown that it is very effective. So it reduces risk for serous ovarian cancer with like a 50 to 80% risk reduction. So huge, huge reductions in risk. And there are now 24 different countries around the world with recommendations for opportunistic self-injectomy. So this little thing that started here in BC, and Diane Miller really came up with this idea. And in the early days, you know, they got a lot of pushback around this. Like, people thought this was a really wild suggestion to make. And, you know, David tells a couple of stories about people in conferences getting up and shouting at them over this idea. And now this is, you know, quite well accepted practice, and, you know, is FIGO recommended in 24 countries around the world. But yeah, so who needed to be at the table for this to happen? I think so. This is a success story of interdisciplinary collaboration. That's what I wanted you to take away from that. So who needed to be at the table for that to have been successful?
Maybe if there is some genetic mutation in the family of the person, and for other cancers, like for breast cancers, ovarian cancers, or they are at the table for this, I'm not sure.
Yeah. So this is in people who have no known risk. So it's quite distinct from what we do in people with pathogenic variants that increase their risk. But certainly we have worked with folks at HCP, just to ensure that they understand what's going on and are on board. The way that it's translated a little bit more into that community is that now, because of the data showing how successfully this reduces risk for ovarian cancer in the general population, there are now clinical trials. So in the high risk population, it used to be recommended that they get RRBSO, which is removal of both fallopian tubes and ovaries at quite young ages. So this has very significant consequences for people with pathogenic variants that increase their risk in that they're put into immediate premature surgical menopause, which is, a quality of life and a long-term health outcomes issue. And so the way that this is translated with respect to people with pathogenic variants is that there are now trials removing their fallopian tubes and delaying their oophorectomy to try to push that premature surgical menopause to a later date for those people to preserve quality of life and reduce risks. So they've been involved in as much as they're watching and thinking about ways they can provide different care to people with pathogenic variants. But it is an opportunity to increase awareness around counseling about family risk. And so, when we put out videos to patients, for example, we'll always include a little bit of, if you have a significant family history of, and then kind of list those cancers, talk to your provider. So it's a good way to inform people that this is something that should be on their radar.
Would there have been, maybe just because of the kind of uptake of this, would there have been not only people in research, but also frontline care and then representatives from governing bodies from OB, surgical care, and so forth?
Absolutely. Yeah. So if you want clinicians to change practice, you have to bring all of those folks to the table, right? You have to explain very clearly what you would like them to do, why you would like them to do it, what evidentiary basis you have, all of those things. Yeah. So those people were all key. Anybody else? Yeah.
I was thinking, just to think out loud, maybe, as you said, when there was a lot of pushback from this initial kind of idea of opportunistic self-injectomy, having collaboration with ethicists to kind of come up with plans on to kind of outline how that this could be achieved in an ethical way.
Yeah.
Could be a very valuable partnership, I think.
Yeah. Yeah. Ethical considerations, definitely. Yeah. And if you're asking people, clinical people, to do something different, they need to get paid for that, right?
Yeah.
Is that what you're going to say? Money. Yeah. Yeah. So this was a little bit easier from that perspective in that there was already a code that gynecologists could use, but now we're at the point where we're expanding beyond gynecology and asking general surgeons to do this. And so then that has become a much more important issue around the fee items and ensuring that if you're asking healthcare providers to do something additional, that they are going to be reimbursed. So can you think of anything else when you think about general surgeons and others doing this? So can doctors just do something that isn't normally in their scope of practice without training, privileging? So you've got BCMQI and all of those people have to be on board too, right? So you can start to think about how many different parties have to come to the table and be able to speak in one language, even though maybe they're not used to all talking that way. So, for me as a researcher, I don't know about how hospitals do their privileging, right? Like this is not something that normally is part of my day-to-day work, but if this is something that we want to implement and to, make sure that we can make accessible to as many women as possible around the province, then these are issues that all of a sudden then I have to start, being able to grapple with and talk to people who do privileging and talk to people who, want to do money and, with the health economists too, for example. So Ian Rongvi at the ministry was tasked with figuring out the financial side of all of this. So he and his group went away to do sort of a economic assessment. And I actually ran into him at the Genome BC lunch last week, and he was like, oh, that project was so hard because people could not get their heads around the fact that it was opportunistic. He's like, they kept wanting to cost the whole surgery. And I was like, no, it's not the whole surgery. He's like, I know, I kept trying to explain that to them, but they kept being like the anesthesiologist but all those people would have been there regardless. They're there for a totally different reason, right? Which is the indication that person is undergoing surgery for. And the salpingectomy is just a small addition to that surgery. So it actually becomes challenging for health economists to do their job because they have to think about things very differently than how they're used to thinking about things. But again, we all have to be in the room talking to each other to make sure that we're all on the same page about this stuff. Okay, so is there anybody in the room who hates networking? Yeah, like going to conferences and it's like poster hour and you're supposed to be going around mingling and you feel like you should be like introducing yourself to people you don't know, and it just is a total drag and a burden. At least that's how I always felt about it. And, you kind of feel like the successful way to network is to like collect a bunch of contacts. And back in the day when people had paper cards, you'd be handing your little card out. Maybe I'm really dating myself, but, and collecting a bunch of people's little cards. But then how many times did those cards really ever result in anything? It's not like networking. I think what I have learned over my career is that networking is great. Meeting people at conferences and having conversations is great. If you like doing that, wonderful. If you don't love doing that, I think that's okay too, because my experience has been that networking is really about building relationships and becoming a valued collaborator. And that doesn't happen over a poster hour conversation or, by passing cards around. It really is something that happens over time by being a good, solid, reliable collaborator. So think about the best collaborator you've ever worked with. Don't think about it for long. What's the name or the face that just popped into your mind when I said best collaborator you've ever worked with? What qualities made that person a great collaborator?
They were a very good scientist in their own domain.
Yes. Skillful.
They were open to different ideas.
Yes. Good communicator, open-minded. Yeah.
They made themselves available, so they were willing to meet.
Yeah.
Someone who has a lot of good ideas, but also has a lot of really good practical skills and knows how to action those ideas.
Yeah. Doers, the doers of the world, right? Not just the thinkers.
Someone who has a great network.
Yes. Yeah, often really good collaborators do, right? Because people learn that they are great, right? So, some of the qualities that I thought of when I thought of a great collaborator that I've worked with is reliable, right? You need to know you can count on somebody, that when they say they're going to do something, that they do it. maybe not exactly in the timeline because very few of us manage to do that, but responsive. So somebody mentioned this, generous, curious, respectful, transparent. You know, these are all qualities that you can't know after 10 minutes of conversation at a conference, right? These are things that you have to learn about somebody over time, and you have to have worked with somebody. You have to have spent a certain amount of time, you know, truly working with somebody. So I think that is just to say that if you are not a person who loves traditional networking, that's okay. You will still build a network over time. And, you know, if you are these qualities, if you embody some of these qualities, people will learn that about you very quickly, and they will share that with their network. And all of a sudden, you know, you'll find that your network is growing because other people are introducing you to their colleagues because they know, you know, that you are helpful, that you are reliable, that you are generous, that you are a good communicator, that you are skilled at what you do. You know, all of those qualities are really important and will help you build your network, even if you're not somebody who is super outgoing. Okay, so interactive exercise number 1, build the dream team. So who has a research question? Do you want to use your grant?
Sure, yeah. So the question is, like, how does the vaginal microbiome in menopause impact, or how are symptoms of menopause related to the vaginal microbiome, and how does hormone therapy impact that?
Okay. So who needs to be at the table for this question? Somebody who's not from the RID team, throw out an answer.
People in endocrinology, is it hormones?
Endocrinologist. Microbiologists. Yeah, you need somebody to do the lab work, right?
Probably gynecologists, people that see these patients.
Yeah. Maybe experts in menopausal hormone therapy. Statisticians. Bioinformaticians. Do you get a lot of data from a microbiome study? I would think you do.
So much and so hard to understand.
Yes. Anybody else?
Maybe some like people with lived experience partners in terms of like whatever the outcome may be, like if you're proposing like any type of knowledge translation or like mobilization strategies, that it accounts for like their acceptability.
Yeah. Do you have all those folks already?
I can tell you we have a microbiologist who does the bioinformatics. We have clinical experts, patients with lived experience, gynecologists and everything. So
yeah.
Biostatistician. Yeah, I think we do have most of those people.
Okay, and how will all of these different disciplines contribute unique insights in this case? Like, is it clear sort of who's bringing what role and expertise?
I think it's clear like what expertise everyone brings. I think one of the issues we're kind of having is everyone's coming from such unique perspectives. They don't necessarily agree on stuff. Like the clinical experts are seeing things quite differently than the microbiome expert, and like pulling all of those into one cohesive narrative is what's been challenging.
In this sense, when you say seeing things differently, do you mean like they kind of have their own idea on what question they're asking and answering?
I think especially from the clinical perspective, there's so many unknowns, and they're interested in specific clinical questions, but our study that we're trying to do is a little more foundational since there is nothing about the postmenopausal vaginal microbiome. So almost like jumping ahead a few steps. So we have to keep reeling it back in a little bit.
Right. And are these people that you guys have collaborated with before? Yeah. So you know them all pretty well. Yeah. So you didn't have to approach anybody cold. No.
Previously, though, like we've written this grant like 3 times. So originally, the first time, some of those people were cold-ish approaches. Like Dr. Money has a pretty big network, so she's connected with people previously. But it's not like everyone we've worked with really closely. Like Dr. Money's worked with this microbiologist for many, many years, so that's a really strong partnership. But it's sort of new to us to be in the menopause space. So that's sort of new clinicians compared to some of our long-standing collaborations.
Yeah. Okay. So in terms of approaching potential collaborators, I guess my advice on this front would be to be really curious. So, trying to understand what that person does, what they're particularly interested in, because sometimes, you can end up derailing your grant if you end up with a collaborator who's really focused on area A and your grant is actually more about area B. And then you find you just spend a lot of time and energy trying to refocus to area B all the time. Do your homework, offer value. So I think being clear about what it is that you are bringing to a project and what value you're offering to that collaborator is really key. And then follow up, which is honestly is something I don't think we always do very well in academia. So we get really busy and we have so many different projects on the go that it's really easy to drop things. And I know that this can be particularly true when we're working with people with lived experience or patient partners where, we're really keen and we bring them in at the beginning of a grant and we, have them contribute to all of our ideas. And then we go really quiet for a long time and they're like, what happened? Sometimes to the point where they don't even necessarily know if the grant got funded or not. So that's one thing to just really be mindful of is to ensure that you're providing good follow-up when you're trying to make long-term collaborations with people. Okay, and collaboration pitfalls. I was trying to think of as many collaboration pitfalls as I could, and they all kind of ended up falling into one of these 3 buckets, but I'm very open to hear if somebody else has other pitfalls that they want to add. So unclear expectations, when somebody doesn't really know exactly what their role is on a project or exactly what the project is trying to do, that will always cause issues in the long run. Poor communication. This is probably speaks for itself. When I started to think about these 3 buckets too, I was like, so is it all just poor communication? Because unclear expectations is a communication issue too, right? And also is undefined role. So if people are, sort of not working in the area that you think that they were coming in to work on, or sort of overstepping what their role in the project is, that can cause real issues too. But again, that often comes down to poor communication. And most of these are preventable through better communication. Yes. So yeah, I think this one really ends up being huge. And, I don't think anybody ever has any intention to go in and be unclear. I think one of the things that is common in research is that we assume that other people are seeing things from our perspective. And I think that's one thing that I've learned over time is that you absolutely have to try to take yourself out of the situation and look at it from a higher level to say, let's make sure that absolutely everything gets clearly articulated so that we're all working on the same goal together. The other thing that can happen is that you can feel like you really clearly articulated something, but the other person still didn't hear it that way. And so Another part of communication can be to make sure that things are written down in documents that people can refer to. One of the things I always tell my graduate students is, spending a lot of time on your thesis proposal, it's never wasted time, because yes, it means that you plan your project really well, but it also means that everybody on your committee sees a document that very clearly delineates what your thesis is going to be. And you get to point back to that document anytime somebody says, but what about this? Maybe we should go and do blah, blah, blah with it. And you can say, that's so interesting. Yes, that's a great question, but this is what we're doing. Remember when we all agreed to this, right? And so, in my lab, people do tend to spend quite a bit of time getting that proposal just right. And then we have the whole committee sign off on it. And then that's a unified, cohesive, clearly communicated goal for that person's thesis project. And, sometimes you still deviate from it because research is research. But when deviations occur, it's always, for a very good reason with everybody on board. Yeah.
I also wonder whether, perhaps associated with the undefined roles, but maybe not really, because sometimes roles can be defined and this still happens, but there's the inequitable distribution of labor, particularly when it comes to not only the labor that's been undertaken in the work itself, but then also disproportionate recognition in terms of who does what and who gets acknowledged for what, I think can breed mistrust and dissatisfaction in teams.
Right. So I did think about some of those issues, and I kind of lump that in under communication too, because I think that's a really key part as well, is to have conversations, because the other thing with interdisciplinary research is that there's different norms across different disciplines. And so, you might think, oh, it's obvious that, this is my thesis research. I'm going to be doing the vast majority of the analysis. I'm going to write the first draft. I'm going to be the first author. But if you're working across disciplines where that's not the norm, that's not how they operate, then they're not going to come at it with that same assumption in mind. So again, with interdisciplinary research, sometimes you have to articulate a priori, what are the norms in my field? Do they correspond with the norms in your field? This is how this is going to operate. So I tend to have authorship conversations really, really early for interdisciplinary work, because, that's one of those things where if everybody just lays it out on the table before we've gone too far down the road, obviously things change, and so if the person who's doing the bulk of the work changes, then there's a reassessment, and you make that clear as well, that we can reassess this at a later date if we need to. But yeah, I think that's a really important point too, is that there can be really significant disciplinary differences in norms when you're working across a large group. And in medicine, we tend to include a lot of authors. So I think we tend to err on the side of caution, as if somebody was participating in, concept and design, or was a fundamental part of the policy, that we're studying or something like that, we would tend to offer them an authorship position, whereas, some disciplines don't. So being clear about those kinds of things a priori as well. And I think also, to your point, is that there can be differences in norms too around who's going to be primarily responsible for moving the work forward. So, in medicine, we tend to think that largely rests with the nominated principal applicant, right, on the grant, that they're going to be primarily responsible. But that's not necessarily always true across all disciplines. So, and if you really are only doing a piece of the work and somebody else is doing another piece, then that becomes even more key to say, how exactly are you operationalizing your piece while I'm operationalizing my piece? So a hypothetical case study, improving PMOS care. So a team is formed to improve care for people with polyendocrine metabolic ovarian syndrome. The team includes an endocrinologist, a gynecologist, a family physician, a dietitian, a psychologist, a health services researcher, and a patient partner with lived experience. At the first meeting, everyone agrees that PMOS care needs improvement, but the team never clearly defines the project's main objective. The endocrinologist believes the goal is to improve metabolic outcomes such as insulin resistance and diabetes prevention. The gynecologist assumes the focus is on reproductive health and fertility care. The psychologist is interested in addressing the mental health impacts of PMOS, while the health services researcher assumes the project will focus on reducing delays in diagnosis. Several months later, team members realize they've been working towards different outcomes. So what pitfall do you think happened here?
I think for communication.
Definitely for communication. Anything else? Yes, unclear expectations. Yeah, but you can see, right, these are all people who are coming at a problem that they care a lot about from their disciplinary lens and their particular norm, right? So to them, and I think this is really common, you know, what you're immersed with every day is going to feel like the absolute priority to you, right? When you come to a problem, when you come to a team. And so there's nobody's doing anything bad here. All of those things are really important and probably to each member of this team, the most important issue. But, you know, when you're doing interdisciplinary research, you definitely want all these perspectives. Like you need to know what the endocrinologist thinks is the most important piece, what the gynecologist thinks is the most important piece, what the psychologist thinks is the most important piece. But then you all have to coalesce around a common goal, right? And not just have people working towards the part of the problem that they see every day. Okay, it doesn't get better. As the project progresses, communication becomes inconsistent. Everybody's really busy, right? You can imagine how busy all of the people on that team are. Meetings are infrequent and key decisions are discussed among smaller groups between meetings. The patient partner is surprised to see a draft care pathway that focuses primarily on clinical management, does not address the diagnostic journey, stigma, and quality of life challenges they had repeatedly raised. Team members assume others are aware of decisions that have been made, but information is not shared consistently across the group. What's the pitfall here?
Communication.
Yes. And again, you can see how like these things happen and it's not, you know, misintentioned or, you know, everybody's just busy. They're all sort of not quite on the same page, working to different ends, and then, you know, ultimately members of the team end up feeling like their perspectives and what the value they bring to the team gets left behind, right? And, you know, really the only way to prevent issues like this is to have really clear communication, regular meetings, frequently coming together. Okay, so when it comes time to prepare a grant application, confusion emerges about responsibilities. The family physician believes the health services researcher is coordinating stakeholder engagement. The researcher assumes the clinicians are responsible for recruiting healthcare providers. Meanwhile, both the endocrinologist and gynecologist have independently developed different versions of the proposed care pathway, each believing that they were leading that component of the project. Important tasks are duplicated while others are overlooked entirely. So again, here, I think this is just more another example of what can happen when you have undefined roles and poor communication at play in an interdisciplinary team. So which pitfall, unclear expectations, poor communication, or undefined roles do you think had the greatest impact on the project's lack of success?
I think for communication is very important, as you mentioned, and I think it's very important to address all challenges and all conflicts at the first stages and just reassess the process if we have made any mistake in communication, in planning, anything. It's so important to address those in the first stages before it gets very challenging.
Yeah, I totally agree. So they had problems that they let compound, right? Rather than addressing them right away when they first realized what was going on, deciding, oh, the way we're working right now isn't working for us. Let's reassess. Let's change how we're going to manage this project. Let's change how we're all going to communicate with each other. They just let things compound, which, can also happen if like members of the team aren't fully aware that miscommunication is happening, right? So the only way to know that you're not on the same page as somebody else is to communicate to some degree, so you can find out, oh, actually they think the project is about X and I think the project is about Y. Yeah. So you think you already did this? What could the team have done during the first meeting to establish a shared vision?
Well, I think you could have a discussion about what you think the project should be, and then everybody can make a shared decision around that vision, right? Because you want everybody to have the same goal in mind. And if it sounds like some of the problem was not having a shared goal in mind.
Yeah. So I think hearing from all of those, the reasons you brought all those interdisciplinary people together is because they absolutely have different perspectives to contribute. You want to hear those different perspectives, right? But then as a group coming together to prioritize, okay, what's feasible for us to accomplish in this project? What can we all do together based on the resource constraints, feasibility constraints, all of that? So, maybe the most important question is something to do with the endocrinologist and, metabolic hormone measuring, and we need new AI techniques or something like that. But perhaps that's not feasible within the confines of your budget so then you would move your priority to what can be accomplished and what everybody can work on together.
One comment online from Boulder.
Oh yeah, I was thanks, Gillian. I was just gonna say the sort of how could this be addressed? I know one of the things we've used in the past as well are project charters. So, to Emma's point, grants get resubmitted and people's roles and interests change. And so forming a project charter before it kicks off to do that role clarification and priority setting, we found super helpful as well, just as a tool to address poor communication.
Yes. Yeah, that sounds like a great idea. How could the patient partner have been more meaningfully integrated into the project?
You mentioned that in the story that sometimes there was decisions made outside of like the regular meeting format, and I think these are often ways that we can miss the input of patient partners. So maybe like leaving most of the main like planning and decision making towards when the entire team is present, including the patient partners.
Yeah, I think that's really common. You can run into a couple of colleagues at a conference and you're able to sit down and talk about your project, and then you you think, oh yeah, we were all on the same page. We think this is the way to go. And you forget that you didn't get the engagement from your whole team. And, it can commonly be the patient partner that gets left out because they're not at the conference, right? I mean, sometimes they are, it's wonderful when they are, but not always, or not as commonly in the same spaces as the clinical and the research members of the team. But the same thing can go for clinical members and research members, right? So sometimes research members are more likely to be in a space and, making decisions without the clinical members present can cause really catastrophic outcomes. So, one of the things we don't understand as researchers is the reality of clinical care. And so sometimes, making decisions about your research project in the absence of that clinical expertise, then your clinician comes in 3 months later and is like, why'd you do this? We would never do it that way. That's not how the care pathway works. And so then you spend 3 months going down the wrong direction because it doesn't reflect the clinical reality. Right. And so, one of the things that we talk about a lot at GCI is this idea of like from bench to bedside is not really right, because actually it's better to be from bedside to bench, right? Like the clinical people are the people on the ground being like, this is the problem. This is the issue that I can't solve for my patients. And then you take that back to a research context. And then of course, really it's a circle. Yeah.
I think to that point, sometimes it's not necessarily having like everybody in the same meeting. Sometimes it's about actually like accommodating the fact that people do have different schedules and meeting with people in more kind of discrete ways that then actually inform the collective vision in a less necessarily like bringing everybody together type of way, particularly when it comes to people with lived experiences. It can like having that burden of representation in the room filled with people who don't have that lived experience but are experts in this kind of more like hierarchical dynamic can actually like hinder their contributions to the project. So having like conversations with them or engaging them in formal ways outside of these larger group meetings can be highly beneficial.
Yeah, I totally agree. One of the things I like to do is to meet individually with patient partners. So just like if I'm the PI of a project, obviously the patient partners are going to be invited to the study meetings, but then I'll also schedule individual one-on-one meetings with the patient partners just to sort of check in and say, is this all making sense to you? Like, is there something you've been thinking about that you haven't, felt comfortable to say in the group, or just to offer, not even to ask that, but just to offer that opportunity. So we have a chat about the project and, talk about how everything's going from their perspective. And you will hear things that you don't hear in the larger group setting, like very valuable input often. So it's a great point that, offering people the opportunity to provide feedback in different settings in different ways can be really valuable. So, sending written documents, if you're going to send it to all of your co-investigators, send it to your patient partners too. They will look at it and they will have really important feedback for you. And pay your patient partners for their time. Always pay them. What practical tools, we heard one, project charter, could have prevented these issues? I mean, any of those things would have helped, right? Any or all of the above. Okay. So I had another example just in case we went too quickly, but I think we're starting to come to the end of time. And so just open up for conversation, reflections. One thing I would say too that I didn't put on the slide, but I think is a really something that I've learned a lot over the years, and that's really challenging about doing interdisciplinary research, is that you absolutely have to trust your collaborators because you're not an expert, right? And that can be a very challenging position to be in as a principal applicant or the leader of a project to recognize that you're handing over this huge piece of work that you don't actually have the skills to do, or even to necessarily know with 100% certainty that it's being done properly. So you just have to find collaborators that you really fundamentally trust. And, that does take time. It takes, networking in terms of talking to other people who've collaborated with that person and, doing your homework, reading their papers and all of those things. But you do need to really have a high amount of trust when you do interdisciplinary work. Okay. We're almost at the hour, right? Yeah. Does anybody want to have any comments, questions, things they want to share, experiences that have gone well or not well for them? Thank you all for participating. It would have been very challenging if nobody had jumped in, so I appreciate it. Thank you.